Okay, thank you, Sam. Thank you for the heads up. So, with this, I think we'll go to the first case. I'll be showing around 4 to 5 cases. Um, Most of them, creating diagnostic dilemma, and sometimes the diagnosis wasn't even sure till we reached the histopathological diagnosis and surgical outcome. So, hope you will we will have an interactive session, and please feel free to jump in and make any comment. If you have to stop me if you want to, that is okay. It's not a lecture. These are some of the slides I've put in with the summary of the cases, and I would love to have your opinion. If you think that there could be more differentials, or there is any other test that could solve the diagnosis, then I think you're most welcome. Thank you so much for joining. So, this is regarding a 66-year-old gentleman who came to us with a history of chest pain. But I'll go back in time and talk about his previous history first. So, he had stent to distal RCA in March 2023, and then he was fine after the procedure, asymptomatic, no peri-procedural complications. So, after around 3 months, he started having non-specific chest pain again. And that was in June 2023. So, 3 months down the line. And now, of course, the cardiologist believed that there could be like something related to the stent, or there could be in-stent restenosis, or maybe he's having some other coronary artery disease, which has now become significant. So a CT angiogram was done to rule out something else, you know, and it showed no significant coronary artery disease in the LED and LCX. And this was the status of the distal RCA stent over here. So I have the stills, I'll show you there. Yeah, this. So what we noticed is that there was around 50% stenosis just proximal to the proximal edge of the stent over here, and there was some intraluminal hypodensity, which was instant, neointimal hyperplasia, which was not causing any significant stenosis. It was mild intraluminal, hypodensities were seen, and the stent was patent. And then the distal vessel was also unremarkable. There wasn't any significant stenosis here, but there was up to 50% stenosis at the proximal edge of the stent. Now, this is the another view, and this shows the hypodensity that I was talking about. Having said that, it was less than 50% of the intraluminal area. Now, so what what something else that we saw retrospectively, but I'll talk about it now because I'm showing the CT here, is that there was some mild haze in the perivascular fat over here. If you can appreciate, like it is not clean like this, there is some mild hyperdensity in the peristent region. Now, this was not something that was considered significant at that point of time. So the comments were made about the 50% less than mild in-stent stenosis and 50% proximal edge stenosis. So after that, the patient was then given medical management. He was okay, and then he had a few episodes of infection in between. There was history of dental treatment. He had some flu episodes which were prolonged, and then with that, multiple fever episodes. Sorry. Okay. So so he was treated with antibiotics, and then he started having episodic mild fever since January of 2024, myalgia. So he was fine, he was being symptomatically managed till then, and he started having mild fever since January of 2024. So a CT was done again to see whether there was any chest infection or anything. Why is he having fever? And you can see now how dramatically different the CT looks now. So there is presence of moderate pericardial effusion, and then there is pleural effusion as well. There is some collapsed lung parenchyma. There is some consolidation in the left lower lobe over here with air bronchograms here. And so the CT showed pericardial effusion, bilateral pleural effusion, left more than right, and there was presence of lung consolidation as well. So CT angiogram was done in the same sitting, and it showed the same findings about pericardial effusion. And regarding the stent, if you can appreciate, now this intraluminal hypodensity has increased. The whole stent was appearing obstructed. The distal vessel was not very well seen in these current CT angiogram that was done around 6 months later, the first CT angiogram. So the stent was obstructed, and now you can see there is a lot more peristent hyperdensities appreciable. So there was an obstructed stent, and these are the delayed images that show um, enhancement of both the visceral and the parietal pericardium. There is pericardial effusion inside, and there is enhancing pericardium in the delayed images. And if you can also appreciate, there is this peripherally enhancing collection around the stent here. This is the peripheral enhancement, and then there is a collection. So it is not very neat. Initially, in the initial CT scan, it was less, but in the current CT scan, it has increased the peristent hyperdensity, and now it is actually a peripherally enhancing collection with enhancing pericardium. So this is the difference between the two CT scans that I showed. So with this, the possibilities now were of peristent infection with a peristent abscess. That was the first possibility that came to our mind, and it is not very uncommon in India to have peristent infection. Otherwise, in literature, it is a very rare complication. Then of course, there was another differential was that probably the pericarditis, that because we saw that there was pericardial enhancement here, so there was definitely a component of pericarditis. So probably the pericarditis appeared first, and then it led to and then there was stent occlusion due to unrelated causes. But this was less likely because there was some sort of peristent, soft tissue, peristent enhancement. There was this dirty peristent fat pad that was seen. So peristent infection seemed to be the first starting point, which led to all other complications. Then there were several other differentials, like, say, thrombotic mycotic aneurysm around the stent. This is more commonly seen acutely after the procedure, maybe within weeks' time. And usually the onset is very aggressive. Usually the patients would be septicemic. There would be contrast filled outpouching, which we did not see in our case. Another possibility is of a stent-induced inflammatory response or hypersensitivity. It's called Kunis-like reaction. It is common with the first generation nitinol stents, where the polymer used to generate this sort of hypersensitivity, and it led to some sort of peristent inflammation, fat pad dirtiness, and then early persistent edema. But this was less likely the cause because this complication is not usually seen with the newer generation stent. Having said that, it is not absolutely rare. Sorry, it's not absolutely impossible. And then dissection, hematoma surrounding the stent, malignancy were other considerations. But the peristent infection was the first in our differentials. So we went ahead, we did labs for the patient, inflammatory markers were done, and surprisingly, we saw that the markers for infection were all normal, like procalcitonin was normal, neutrophils was normal, blood urine culture were normal. So no signs of infection, except for the fact that the patient presented with evening rise of temperature. Every now and then he had fever. Inflammatory markers, on the other hand, were positive. So LDH, CRP, D-dimer, ferritin, all the acute phase reactants and inflammatory markers were positive. So there was definitely some sort of inflammatory response there, but we were still not sure whether there was infection or not because the labs were negative for infection. So FDG PET was done as well, and as expected, it showed uptake in the region, in the peristent region here. This is the inflammatory node that was seen, or an infective node. There was uptake in the lymph node here, in the mediastinum as well. So the patient was considered okay. So probably the infective markers were negative, but we considered that the patient might be having peristent infection. So the patient was treated with broad spectrum antibiotics for 2 weeks. So after 2 weeks time, there wasn't much significant response clinically, and the and MRI was requested by the cardiologist to have a look at what is happening. Maybe some sort of tissue characterization could be done. So the MRI revealed an ISO around, if you can see in the MRI, there isn't much pericardial effusion now. So the pericardial effusion has definitely subsided in an MRI. And I'm not sure how I can see the questions if they are raised during the. Probably I'll have a look at it later. But feel free to say if you have to interrupt me. Yeah, so the MRI revealed this soft tissue lesion around the stent. There wasn't much pericardial effusion now, but there was pericardial thickening still. So this was after antibiotics for 2 weeks. And in the perfusion, there was appearance of, first pass perfusion within this lesion that was around the stent. So these were the MRI findings. So on T1, it's iso-intense. On T2, it was slightly hyperintense. The lesion around the stent. On Cine, it appeared iso-intense. There was some first pass perfusion. And in the early gadolinium enhancement, you can see there is peripheral rim enhancement around this lesion. Sorry. And in the delayed late gadolinium enhancement, you can see there is intense pericardial enhancement, as expected, as was seen on CT as well. There was definitely decreased pericardial fluid, and the important finding here was this peripherally enhancing lesion. So MRI did not reveal anything extra, it just showed resolution of the pericardial fluid, but this lesion was still as inflammatory as was visible on the CT earlier. So the diagnosis on the basis of imaging was still chronic peristent infection. Now, so this was the diagnostic dilemma that the infective markers were all negative. Procalcitonin, the WBC count, all were negative. Cultures were negative, but still the diagnosis of chronic peristent infection was considered. Um, any idea, like, are there any infections that could probably cause this sort of response? If anyone wants to chip in. Okay, so we went ahead and okay, I think the sound is when people join, right? Like, or leave, not when people say something. So yeah, so that was a dilemma, but yes, so the situation I mentioned, that absent the normal lab parameters but findings of infection or inflammation on the imaging, that can happen in some of the infections, like indolent infections like atypical mycobacteria, brucella, sometimes these low grade infections like actinomyces, brucella, or atypical mycobacteria, these can incite chronic granulation tissue. As we saw in our case, the lesion around the stent did not look like a frank abscess. There wasn't much liquid component there. It appeared to be more of tissue, which showed first pass perfusion. So it appeared to be a granulation tissue sort of thing. So this can also happen in low grade infections. And this sort of situation is seen commonly in tropical countries or Indian subcontinent. So we made a diagnosis of chronic peristent infection. Sorry. So the patient was started on anti-inflammatory therapy as well, like colchicine, etiocox, etc., antibiotics, uh, and sorry. So the patient improved symptomatically, dramatically actually. On 10th day, he was absolutely fine on starting the treatment, but there was a concern of residual pericardial thickening. So the patient was discharged from the hospital, and but within 1 month, the symptoms reappeared. So now the plan was to excise the tissue surgically and then see the histopathology or microbiology of that particular lesion. There was a multidisciplinary team effort here, because it was a very difficult surgery. So, of course, imaging, clinical, and other parameters were also optimized. And the surgeons went ahead and did a surgery in this particular case, and the stent was explanted, and then the culture of the tissue that was seen from that was taken out. revealed Mycobacterium abscessus. This is a non-tubercular mycobacteria. So, the diagnosis of chronic peristent infection caused due to an indolent infection like atypical mycobacteria was confirmed on the surgical findings or histopathological findings. So, this patient was then instituted mycobacterial treatment, prolonged antimycobacterial. So usually in Mycobacterium tuberculosis, we give around 6 months of antitubercular treatment, but in atypical mycobacteria, these are indolent lesions, not very responsive to antimycobacterial therapy. So prolonged treatments are sometimes necessary. Symptoms improved, and at 1 year follow-up, the patient did not have any fever and did not show any sense of collection on imaging as well. So this was a case of chronic peristent infection. So the most common organism for a peristent infection is Staph aureus. Sometimes Streptococcus, Pseudomonas, Acinetobacter. These are some other organisms that are also seen, and not necessarily the infection is due to implantation during the procedure or unsterile conditions during the procedure. Many a times it can happen after dental implants, or there is some sort of septicemia, bacteremia. It is extremely rare to have this chronic stent infection in a healthy person. So there is some amount of immunocompromised status also involved over there. But this particular patient was absolutely fine, he's healthy, but still he developed this. Two-thirds of the patients can have aneurysms alone or with restenosis of the stent. In one-third, you can have blocked vessel. Like in our case, there was stent obstruction. Most commonly, chronic coronary stent infection occurs within the first week after stent implantation, and late cases are very rare. And whenever the patients present late, very late, say 6 months down the line, then think indolent infections, because these definitely progress slower, but when they progress, they have a very aggressive presentation at follow up. So in our case, looking back in time, when we saw the initial CT, there was mild haze around the stent area, which could prompt early picking of this particular disorder. And the right coronary artery is again the most commonly involved artery. They say there could be things related to the hemodynamics within the artery, or the angulation, or its closeness to the adjoining pericardium. Now, associated pericardial thickening or effusion can occur in majority of the cases, up to 80%. In our patient also, there was associated pericardial effusion. So this was my first case of chronic peristent infection. With that, let's see the second case. Are there any comments or any doubts regarding this particular case? Any alternative opinions? No? Okay. Okay. So with that, I'll go to the next case. So this was a 10-year-old girl who underwent surgical correction for complete atrioventricular septal defect at 4 months of age. Now she's 10-year-old, and she now presented with progressive worsening of exertional dyspnea for last 1 year, gradually progressive. Clinical examination was otherwise normal. Rest ECG was also normal, and this was the echocardiography findings. Any comment? The findings are written over here, but if someone is adept in seeing echocardiographic images, would you like to make any comments here? Okay, so there was presence of echogenic soft tissue that was attached to the anterior mitral leaflet here, and then it was projecting into the left ventricular outflow tract, and this was causing left ventricular outflow tract infection. There was mild mitral regurgitation as well. So there was left ventricular outflow tract obstruction, and there was mitral regurgitation as well, due to a echogenic soft tissue that was attached to the anterior mitral leaflet. Now, this word echogenic is important because we'll see how we differentiate it from other conditions. No residual atrioventricular septal defect was seen. So the surgery was okay, that the patient underwent at 4 months of age. So what is the next investigation that you would like to do? MRI or CT? Anyone, any preferences with this finding? Okay. So basically, either could be done in this particular case. Both have their own advantages and disadvantages. We went ahead with doing a prospective ECG gated CT angiogram to delineate the extent. Three-dimensional reconstructions really make it easy to see, the attachments of the tissue, and we feel more comfortable with doing that on CT angiogram. So we went ahead with a CT angiogram. However, we do an MRI in this particular setting, then of course we'll have additional information regarding the regurgitation, the LV outflow obstruction, the gradient, volumetric quantification can also be done. So it's a question of choice. I would say probably MRI could give you more information. We went ahead with doing a ECG gated CT angiogram in this setting. So these are the images that we have. any any comments? Any diagnosis with these images? Any abnormality that anyone can see? Feel free to say. Yeah, okay. So there was a tissue that was seen attached to the anterior mitral leaflet here, and it is going into the left ventricular outflow tract here. This is the aortic valve, and this is the tissue here, and this is also going towards the, so you can see the left ventricular outflow tract is being encroached by this tissue that is present. This is better seen in this image, wherein you can see the tissue attached, some part of it is attached to the base of the septum, interventricular septum as well, and you can see it is projecting into the left ventricular outflow tract and closely abutting the aortic valve over here. So the attachment is with the anterior mitral leaflet, and then that it is abutting the aortic valve over here, and then it is coming down and attaching somewhere here. So I've seen the scenarios, hence easy to make the diagnosis regarding the attachments over here, but it can sometimes be very challenging unless because it's a mobile structure. So in the, this is the aortic valve view, wherein you can see the tissue as well. So okay, so the abnormality was in the region of the mitral valve, a soft tissue attached to the mitral subvalvular apparatus along the anterior mitral leaflet, projecting into the left ventricular outflow tract, causing a fixed LV outflow obstruction. So what is the diagnosis? Anyone? Any comments? No? Okay. Is anyone typing something that I'm not able to see? This first time I'm using this platform. So, okay, so there are, okay, sorry. Okay, okay. Now I can see the chat. I'm really sorry, guys. I'm go to meetings knife. So, okay, I'll come back to the question later. So, this was a case of these were the differentials that we had on the basis of images. Subaortic membrane, an accessory mitral valve tissue, a blood cyst attached to the mitral valve, or again a hydatid cyst again attached to the mitral valve. And again, hydatid doses is also commonly seen in India. So these are some of the cases wherein you would find more prevalence of these, these disorders in Indian or maybe tropical countries compared to the Western population. But hydatid cyst was also a differential in this particular case. So how did we differentiate? So for a subaortic membrane, I think I have a slide later. Yeah. So a subaortic membrane should be present in the region of the just below the aortic valve. It shouldn't extend to the mitral valve region. So this is the typical location of a subaortic membrane. It can be partial, but it shows attachment to the left ventricular, the septum, part of the outflow septum, and the aortic valve, just below the level of the aortic valve. And the accessory mitral tissue is attached to the mitral valve apparatus. So this is the finding that differentiates between the two. You won't see a mitral valve attachment in a subaortic membrane. Second differential is a left ventricular blood cyst. Now, this is one of the case I've taken it from a case report wherein a similar tissue can be attached to the mitral valve. But usually a blood cyst should be round or it should be oval. And on echo, it will appear like a cyst. It will appear like a lucent area which is surrounded by a thin membrane. So this was also ruled out. The diagnosis that we made was a accessory mitral valve tissue. In hydatid cyst also, usually it's a circular rounded thing, but sometimes ruptured hydatids can also look like this. But usually in hydatid cyst, you will find undulating membranes inside. So there will be a cyst, there will be a pedicist, the covering, and then inside of it you will find some undulating membranes that are seen within the hydatid cyst, which is not seen in this particular case. So this was a case of accessory mitral valve tissue. It is a congenital cardiac hematomatous condition. It can be seen alone or in conjunction with the congenital heart diseases. In our patient, she underwent an AVSD repair at 4 months of age. So someone could say that there could be, why was this tissue missed at that point of time? So it is very common because accessory mitral valve tissue can show stealth behavior. Sometimes it can go undetected in a collapsed and empty left ventricle during the cardiopulmonary bypass that is instituted during the surgery. And this is the reason that probably this tissue was missed at that point of time. And over a period of time, as the patient grows, it prolapses into the LV outflow. So it is all attached to the left, it is attached to the mitral valve leaflet, but it is prolapsing into the left ventricular outflow and causing left ventricular outflow tract obstruction. It can present with dyspnea, chest pain, arrhythmias, LV outflow obstruction. Our patient had a mild concentric LV hypertrophy on echocardiography, so probably due to a chronic left ventricular outflow tract obstruction. It can also house a thrombus and can cause embolic showers. So it is important to identify this. So when I saw this particular case, this was my first time seeing, I was doing my fellowship in cardiac imaging at that point of time. And this was my first time seeing this. So this is one of those cases wherein if the mind doesn't know, the eyes don't see. You have to know about this entity in order to diagnose this entity. So it can appear like this. So and it may look like a mobile parachute like leaflet because it's an accessory valvular tissue. So if you excise this tissue, you will see the myxomatous valvular tissue that is seen in a normal mitral valve. It undergoes a progressive thickening over the time due to hemodynamic effects and can cause stenosis of the left ventricular outflow tract. It can appear as a globular or cystic mass if it becomes too redundant, enlarged. In those cases, it can be very difficult to differentiate this from, a blood cyst, and it prolapses into the left ventricular outflow tract or aortic valve during systole and retracts during the diastole. So it can be really mobile. There is a classification of this entity. So there is very limited literature, but there is some literature on this. So type 1 is the tissue which attaches to the mitral valve and then goes and attaches somewhere above the level of leaflets. In this case here, it is attaching to the atria. Type 2, which is the most common, wherein it is attached to the mitral valve leaflet. So both ends are on leaflet in type A, but what it does is that it goes into the LV outflow and comes back and attaches to the mitral valve. So probably our case was a type 2A. As I showed you, it prolapsed into the LV outflow and came back and attached into the mitral valve. But it can also have another end attachment at the lateral wall of the left ventricle. In the left ventricular outflow tract. So this is a type 2B, 2B AMVT, and type 3 attaches below the level of leaflets. So it can show attachment to the remote left ventricular wall also. So there are these three types. And if I can show the image again, we felt like it started from here and then went into the LV outflow. It is abutting the cusps of aorta valve over here and came back and attached to the mitral valve leaflet over here. So we felt like it was type 2A probably. Now this, so when is the surgery recommended? So usually approach is to submit for so the patient can go in for intervention only when there is significant LV outflow tract gradient. The literature has defined it to be 25 millimeter mercury for this particular entity. And if it is causing significant stenosis, there can be complete resection of the mass tissue can be done, and then mitral valve can be reconstructed. A follow-up with if those patients who are without significant left ventricular outflow tract obstruction, follow-up with serial echocardiogram can also be done to assess for progression of the gradient. And if the gradient goes into the obstructive range, then the patient can be prescribed surgery. So this patient was also prescribed surgery. Um, any comments, any doubts, anything, any? Okay, yeah. So I think there were three comments before, right? So how is the infected stent managed? I think I covered it at the end of the previous presentation. So usually we get, in this particular case, we managed it with antibiotics and antimycobacterial treatment, and then the patient was then sent for surgery. So that was the prolonged antimycobacterial treatment was the management. I'm sorry I missed your message during the last case. Myxoma, yes. So a myxoma can also be considered a differential. I think this comment was made before I showed the entire case. But yes, so myxoma would be usually a solid tissue. We will see some necrotic areas in between, but this particular case that I am showing, there is, you know, it is blood filled, so it shows the same contrast intensity. So it is not a solid lesion. So definitely it was something that was in contact with the blood pool, and it is appearing cystic and not solid. This should have been seen prior to cardiac surgery. Yes. So ideally, it should be seen prior to the cardiac surgery. This patient underwent the surgery at 4 months of age, and we got this presentation at 10 years of age. We assume that that happened because of a collapsed left ventricle during the surgery, during the cardiopulmonary bypass. But yes, it should have been caught in the preoperative echocardiogram. And echocardiogram has been shown to be equally good in catching this particular entity, but definitely it was missed at that point of time. So this was my second case. With that, I think we'll go to the next case. So this case is slightly different, as in we are moving out of the heart, maybe into the vasculature. We do a lot of vascular imaging as well. And so this was a 2-year-old boy who presented with fast breathing, cough and fever for 1 week. And the chest x-ray was done, and it showed this. Any comments regarding the finding in this particular chest x-ray? Okay, so there was
Maybe tamponade, like large pericardial effusion.
yes. So definitely there is cardiomegaly, and we have to assess the cause. Thank you so much for answering. So there is presence of cardiomegaly. The cardiothoracic ratio has increased. It could be due to anything, enlarged heart or pericardial effusion or tamponade, as you correctly pointed out. So what is the next investigation that would like to do? CT, MRI, echo, PET?
I was
Nothing.
starting
Sorry, can you repeat? Sorry.
to start with an echo.
Echo, of course. So that is the first investigation of choice with this particular finding. An echocardiogram was done, and it showed pericardial effusion, as you correctly mentioned regarding the findings. You know that there was this, the pouch like appearance, a bag of waters like appearance of the cardiac silhouette, and there was presence of pericardial effusion on the echo as well. So the blood labs, there wasn't anything very significant. TLC, DC, everything was normal. The inflammatory markers were also normal. So with that, what do we do next? So we did a CT. because we were thinking that probably there was some sort of chest infection that is being missed. The patient is presenting with fever, cough, fast breathing, and CT was done, which and there was a pericardial effusion. So we wanted to see if there is anything that is present over there, and you can see the pericardial effusion here as well. But in addition, what we found on CT was presence of this, soft tissue-like thing, which was seen in the mediastinum. So it was not thymus. It wasn't just limited to the thymic area of anterior mediastinum, but also around the arch vessels, there was some sort of soft tissue, dirty soft tissue that was being seen. There wasn't clear, mediastinal fat that was seen in this particular case. And then there were some strands of fibrotic strands. There wasn't any active infection in the chest. There wasn't any consolidation, but some prior infection might have happened. There was some infective strands that were seen across the chest. So the pericardial effusion was then tapped, and it showed chylous fluid like this. So this is from the patient, and it showed chyle with a triglyceride very high. So there is chylous pericardial effusion. Um, so what would you do? Like any comments regarding what should we do next? What any other investigation that anyone would like to do? Yes. So in this particular case, since we thought that, so some sort of mediastinal fat stranding that was seen on CT with presence of chylous effusion, we wanted to do a filarial smear was negative. So we wanted to image the lymphatics in this particular patient, because this can happen when there is some sort of chylous leak within the pericardium, and it can lead to soft tissue abnormalities like that, which was seen on CT. It can also lead to chylous effusion. So how to image the lymphatics now? Before going into the types of lymphatic imaging, because already we were considering that there is some sort of chylous leak, to reduce the symptoms of the patient, it is recommended to start on medium chain triglyceride diet, because it leads to reduced flow within the central lymphatics within the thoracic duct which traverse the mediastinum, and symptomatically the leak is lesser, so the patients feel better. So medium chain triglyceride diets are usually recommended in these patients who have some sort of pathological lymph flow. So there are multiple methods. Conventionally, there have been oil-based lymphogram wherein we used to cannulate pedal lymphatics, and then the lymphatic drainage was seen how it goes up into the abdomen and then mediastinum. But it was very challenging, time consuming, very skill based. Lymphoscintigraphy again and fluoroscopic scintigraphy, they used to involve ionizing radiation, and of course sometimes the yield was very low, the diagnostic yield of these entities. But with current generation MRI, with current generation MRI scanners, we now have very heavily T2 weighted sequences. We have very good 3D T1 weighted sequences, which can really give us very good images of the lymphatics. So we went ahead with MR lymphangiogram to see what is happening with the lymphatics, what is leaking into the pericardial fluid. So usually the protocol involves a T2 sequence and a dynamic contrast enhanced sequence. So this is the protocol, non-contrast protocol that we follow. Yeah. So so this is the T2 weighted fat SAT sequence in this patient, which showed this the ill-defined hyper intensity in the region of the mediastinum. There is some sort of consolidation also here in the region of the superior lobe, and then it is around the great vessels as well. You can see this proliferative lesion in the mediastinum, again some sort of abnormality, hyperintensity in the upper lobe and around the mediastinum. And this was a T1 weighted sequence which showed iso-intense lesion. So T2 weighted fat SAT, and this is the heavily T2 weighted sequence that was done, which showed hyperintensity in the region of the mediastinum. Now, we did dynamic contrast enhanced MR lymphangiography. So what we usually do is that we place a needle at the, so this is a very small lymph node in this child, 2-year-old child, right? So cannulating the lymph node is very difficult. So these are the images captured from the cell phone. I want to thank my colleague Mansi Verma, who was instrumental in following up of this case, and she had shared some of her slides with me. So really grateful for that. So cannulating is important because you have to place your needle at the junction of the cortex and the medulla. This is where the lymphatics will have the maximum, drainage. So this is where the needle is placed. So this is a small lymph node, and so both sides, both inguinal lymph nodes are cannulated, and then a total of zero point 0.1 millimole of gadobinate is something that we prefer, multi-hands, which shows good lymphatic imaging. But of course, it can be done with any gadolinium-based contrast medium. And then it is diluted for saline, normal saline, and then you divide the entire contrast into half. So half you put in one side, half you do on another side. So usually two operators we do on either side because it has to be done simultaneously. Slow hand injection, zero point 0.5 to 1 milliliter per minute. So after that, dynamic contrast, I have the loops as well, but here what we saw is that we usually follow the lymphatics in the abdomen. You would see a cisterna chyli appearing, and then in this particular patient, the cisterna chyli was seen up till the level of, so this is the cisterna chyli which is seen at the level of abdomen, and as you trace it up, we were able to trace it till D6 level, below the level of carina, and then after that we could not trace the drainage of the cisterna chyli. So usually the cisterna chyli would go up and drain into the angle between the left internal jugular vein and the left subclavian vein, where it forms the brachiocephalic vein, usually in that particular location. And but there are multiple variations of the drainage of cisterna chyli, but in this particular patient we are not able to trace it above this particular level. But what we were able to see was that there was reflux of the contrast all throughout the lymphatics, in all throughout the mediastinum. Here you can see wrapping around the arch vessels here, and here also you can see reflux into the mediastinum. Thoracic duct was seen in till D6 level only. And you can see that reflux is also going into the lung parenchyma along the bronchovascular bundles. These are the hyperintensities that we are able to see. Here also you can see hyperintensity along the peribronchovascular channels. And as we know that there are lymphatics that go around this as well, central lymphatics. So there was reflux of contrast all around the mediastinum and the central lymphatics. So these are the images. So I think I'll just trace it like this so that it is easier. So here you can see the lymphatic channel has opacified, and we are able to see, sorry, if I trace it here, sorry, this is the lymphatic channel, sorry. And as I trace it down, you can see here, you are able to trace it. Here you are able to trace it. And but beyond the D6 level, it was not seen. But what, sorry, this is the D6 level, and beyond that, what we are able to see is this lymphatic reflux. So, ill-defined mediastinal soft tissue, non-visualization of superior thoracic duct, and presence of lymphatic reflux, a likely diagnosis of a complex lymphatic anomaly was made. So that is called a CLA, complex lymphatic anomaly. It has multiple types, and central conducting lymphatic anomaly is one type of a complex lymphatic anomaly. So in this particular patient, skeletal survey was normal. There were no abnormalities with the bone. Sorry for the images captured from the phone. And this particular soft tissue, there are multiple differentials of abnormal mediastinal lymphatic mass. They can be lymphangioma, but it is more focal, well defined. But in this case, it is more of ill defined than lymphangioectasis. So that was also out because it appears in neonates. Lymphangiomatosis is something which causes diffuse proliferation in the mediastinum. So in our case, lymphangiomatosis was considered as the differential. Lymphatic dysplasia syndrome causes chronic lymphedema, mostly occurs in adults. So this was also out. So I told about complex lymphatic anomalies, out of which central conducting lymphatic anomaly is one of the differentials. But why others were out? Because Gorham-Stout disease, which is also one of the central complex lymphatic anomaly, it usually causes bone involvement, brain involvement. In this patient, there were no symptoms related to bones or brains, and then workup was also normal. So all other workup was also done and was normal. Generalized lymphatic anomaly causes bone involvement as well. So it was also out. Kaposi-form lymphangiomatosis is the closest differential to a central lymphatic anomaly. But usually it causes thrombocytopenia. In our patient, there was no thrombocytopenia. Labs were normal. And it also causes a lot of visceral involvement, like liver and spleen involvement. And it was normal. The ultrasound was normal in our patient for liver and spleen. So Kaposi-form lymphangiomatosis was also out. So central conducting lymphatic anomaly was the final differential that was considered. So usually the management can be surgical excision, but it is tricky because the margins are very diffuse. If you see a distinct leakage of the fluid, you can go and we do a lot of interventions as well. So you can go and plug, glue, put lipidol or coil that particular leak as well. But in our patient, there was a diffuse reflux. There was no particular point of leakage which could be blocked via endovascular intervention. Then the third therapy is the newer mTOR inhibitors have also been shown to be effective in these patients. So sirolimus therapy is also considered. Our patient was instituted sirolimus at zero point 0.8 milligram per meter square dose by daily, twice daily. And these are the follow-up images after 6 months. And you can see how the pericardial effusion has absolutely subsided. And this is the X-ray of the patient. And you can see on the dynamic contrast enhanced T1 weighted images, there is no reflux of contrast now. So these patients, respond dramatically to sirolimus therapy. And that is why making a diagnosis is so important. And MR lymphangiography really is an instrumental. It's a life-changing tool, I would say, for these patients, which were earlier, sometimes there were a lot of dilemmas and misdiagnosed many a times these patients. So this case demonstrates a rare clinical entity, which was chylopericardium, presented at a very young age, 2 year of age, and it was caused by central conducting lymphatic anomaly. And these patients respond well to sirolimus therapy. So it's important to have identify these cases. Yeah. Any comments? I think we have like 10 minutes. So should I go ahead? I think I'll just show this last case and we can wrap up after that. Thank you so much. Thank you, Alex. Thank you, CI. So this is the final case that I have. So this was a 12-year-old boy who presented with chest pain for 4 months duration. It was left-sided, moderate in intensity, no complaints, no other complaints were there. So these are the echo images. So you can see there is this pedunculated, also, sorry, this is not the cine image, but there was a pedunculated mobile left ventricular mass from the interventricular septum on echocardiogram, and it was very mobile. Any differentials? Um, any differentials that you would think of? One, two, three. In the interest of time, I'll go ahead and we can probably discuss later. So the possibilities are of a mobile thrombus, which is the most common mass involving the heart, rhabdomyoma, fibroma, exoma, lipoma, anything, any benign lesion. Benign, why? Because it is very well delineated, but we will evaluate it further. But yeah, so these were the differentials that were considered on echo. So what do we do next? I
MRI.
love it. Yeah. So we all love MRI, right? More often than not, it answers all the questions. So we went ahead with a CMR characterization of the mass. I won't go ahead, I won't talk in details about the protocols, but yeah, so I have some nice looking images over here of a mobile pedunculated. You can see the stalk over here, pedunculated lesion that was seen within the left ventricle, and it was seen to be attached to the interventricular septum. The stalk was very thick, anteroseptal segment of the intervention anterior basal LV. It was seen to be attached to, and still the diagnosis. These were the diagnoses. So the CMR based characterization was done. These are the T1, T2 images. So T1 and T2 are really important here because on T1, a lipoma would be hyperintense. Fat is hyper on T1. So it was ruled out. Myxoma is heterogeneous. This is more of a homogeneous sort of. I'm sorry for the artifacts, the breathing artifacts in this patient, but myxoma was also out. This appeared to be very homogeneous on T1 and T2. So we are left with three alternatives: fibroma, hemangioma, and rhabdomyoma. So usually a hemangioma would be hyperintense on T2. This mass was isointense on T2, and a fibroma should be usually hypointense on T2 weighted image. But so it is very easy to say, but very difficult to distinguish. More often than not, T1 and T2 are not able to distinguish unless and until it is just a clear case of lipoma. So we went ahead with other sequences, and on first pass there was mild peripheral first pass perfusion, and you can see how it looks on LGE. It just lights up on LGE like a light bulb, right? Whenever I see images like this, my tendency is to lean towards fibromas, because fibromas show a lot of fibrous tissue, very, but usually fibromas would be located within the myocardium, although stalk based mobile fibromas within the LV cavity have also been described. So these are the differentiating points. So a fibroma, intense enhancement is usually seen, but on first pass perfusion, a fibroma usually does not show enhancement because the fibrous tissue does not take up much contrast on the first pass. A hemangioma shows a rapid peripheral first pass enhancement, which was also not seen in this case, but it doesn't show too much of a LG like this. So definitely not very typical for hemangioma also. And rhabdomyoma usually does not show either first pass perfusion, and even LG is also very minimal for rhabdomyoma. So definitely rhabdomyoma was out in our case, because there was definitely some first pass perfusion, there was enhancement. So, but we were not really sure about fibroma and hemangioma. To be honest, I leaned more towards fibroma in this particular case. These are the T1 ADC maps, did not show any, diffusion restriction. T1 also showed a value of around 1580 over here. I agree with Alex, myxoma, hemangioma, and bingo, Alex, because this patient underwent surgery, and the surgery showed cardiac hemangioma. So that was the final diagnosis. So this was a mobile intracavitary cardiac hemangioma, differentiating it from a cardiac fibroma. Sometimes, specifically this mobile stalk-based fibroma, can be really challenging. So the final diagnosis was of hemangioma, and I think it's only the histopath that made the diagnosis. We had left it at hemangioma versus fibroma. um, I think that's it. Uh, these are the cases, and I think we have 4 minutes to go. If you have any comments or any queries, I'm happy to take them. Anyone has seen cases like this before, like pedunculated intracavitary?
Amazing cases, Vineta. Thank you so much.
Oh, thank you so much, Alex. Thank you. So I think that's it then. Hopefully we'll meet again soon with maybe next set of challenging cases from my lab. And thank you very much, all of you, for joining. And I hope I have answered all the queries. Thank you very much. Thank you.